will give you a few ideas that arise, no conflicts of interest. I will start with a case report. That is Sean White, now 25 years old. With the age of 4 years, he began skiing, but his mother said that he's doing such wild things that she forced him to shift to snowboarding. So he started snowboarding with 6 years. It was difficult to get a board, and they could be helped by a sponsor. And even with the age of 7 years, he has his first sponsorship for that board. With 13 years, he was a real professional with his sponsorships. And he won the American Winter X Games, in total 10 gold medals, 3 silver medals, 2 bronze medals. And also, coming to our topic, to the Olympics in 2006, he won the gold medal in the halfpipe, and he repeated everything in Vancouver. So to get an image how he is training, I give you a small film. That is training conditions for people with...
When we sat down in the beginning of the season, the idea came about to do my own halfpipe, private halfpipe. I sat down with Red Bull and the group I work with there, and it's just unreal. They really kind of came through for me and were able to come up with this idea. It's just an amazing thing to have Red Bull step in there for me and take the distractions that's normally in my ear and just take them out of the picture and let me really explore the boundaries of what I can do and the tricks that I've contemplated over years and never really had the chance or the inspiration to try. Now just sitting there waiting for me to learn.
On his own half-pipe from his sponsors.
It looked like a field of flowers with like a tank in the middle of it. It just didn't belong, but it was so cool because it was there, you know what I'm saying? It was just some weird contrasting, godly half-pipe sitting there, nestled into these mountains. Every single wall was just untouched. Not even the slightest little... it was perfect.
I stop here. Still, it's the end. You should remind that when afterwards we talk about quality of life of patients with congenital heart disease. Oh, I forgot something. He has tetralogy of Fallot, has 2 surgeries in infancy, and he's a patient with congenital heart disease. But the topic is transposition of the great artery, so we had to go on, otherwise I could stop here. So that was a study we recently published. It's only online, but it will soon be printed. We took the basis of her study a few years ago, where he summarized the surgical data from Munich. And you see, in the initial years, we had mustard operations. From 78 on, we did mainly sending operations, and this sending area took till 1939. We started earlier with the switches, but then now are only switches. That is because we had 2 surgeons, and one surgeon did very excellent sendings, and he said, no, he don't have any risk. No child died with a sending in Munich for that time, and he don't want to start with this new risky operation. The other one was convinced that the new one is better, and he started, and so it was a quasi-randomization in this time period, some getting the one surgeon, one getting the other surgeon, and therefore we took out this time period, and now they are almost 20 years old and did a long-term follow-up investigations, who is better. And these results here I'm showing here, the such operation are doing very good. They have an oxygen uptake of almost 40 milliliter per kilo per minute, and the Sennings are performing significantly less with a little bit more than 30 milliliter per kilo per minute. But looking at the percent predicted value, it's even better because the switch patients almost reach the 100%. So the patients that were the normal controls that never had a congenital heart disease. So these are very excellent data from the switch group, and the Senning are poor, or poorer. What is the reason for that? We did the oxygen pulse, which is a surrogate of stroke volume, and you see the switch patients had a very normal oxygen pulse in percent predicted, 100%, and the Sennings have less. The heart rate were the same. With the systolic blood pressure, we also had some differences. The switch could rise their blood pressure better than the Sennings could. And then we see the physiology that is behind it. After Senning operation, you have these limitations to increase the stroke volumes through not good working baffles, calcified baffles, and all this atrial kick we talked about yesterday. Next idea, I want to mention which sport discipline should we advise our patients. And we have to keep in mind that not every sport is really harming or stressing the heart, I would say. We have endurance sport disciplines that are mainly heart dependent. We also have strength disciplines that are more dependent on the muscle. Speed is more the control, how the nerves are connected to the muscles. Coordination is mainly also a neurological problem, and flexibility is just a passive orthopedic problem. Strategy, if you want to become a chess Olympics, then it's not Olympic, but they have also a lot of strategy in it, and also some team spirits. If you, for example, see the rowers, the one that is in the rowboat, the cox, he has nothing to do except giving the motivation to the others. And you see that the heart is a little bit stressed by strength training, but most stressed by the endurance training, and therefore you might know this classification for sport disciplines, but that is a cardiologic classification. Here you have the increasing static components, and here you have the increasing dynamic components. This is endurance. These are highly trained endurance issues, and this is strength. And here you have all the common sport disciplines, and you have to find, for example, running, this marathon running that is low static but very high dynamic sport. And you also have other ones like billiard that is not very intensive for both dynamic and static. Next idea is whether we should allow competitive sport in patients with repaired transposition, and that is a difficult task. I want to think what we did when I came to the Heart Center in Munich. The first answer I got from our outpatient department, the patient cannot do that. It's too hard for him to do such difficult, intensive sports. But is that the right question I want to ask to you? If you see, for example, a 12-month-old infant, he's not able to walk. Should we forbid him to walk? No, he should learn it. That's the wrong question. The correct question is that dangerous for the patient to do sports? And again, this is not really the good question, because also walking is dangerous. The child could fall. But that is a danger that even the child itself can manage and knows, and he realized that that is a danger. He will be very careful in his first steps walking, because he knows and he will fall, but that doesn't harm him. So the question is even not what is dangerous to the patients, it is what are obvious risks and what are hidden risks. And even with the hidden risks, a lot of these hidden risks, the mother can answer to the child. So he should not learn walking on the street, he should work walking at home. The thing we have to advise is whether there are medical hidden risks in that sport activity that could not be foreseen by the patients or by the parents of the patients. That is the question we had. So let's have a look to a very recent study in the New England Journal about a few weeks ago. It was published. About cardiac arrests in marathon events in the United States the last 10 years. About 10 million runners joined these marathon events, and they could find 59 cardiac events. 17 were survived. 42 were deaf after that marathon event. And from all these cardiac arrests, 31 had a complete medical workup, and we know what is the reason for that. And when you look at this pie chart, you will see that are the hypertrophic cardiomyopathies with additional problems, and these are hypertrophic cardiomyopathies without problems. These are probable hypertrophic cardiomyopathies with problems, and that are probable hypercardiotrophy without problems. So about 1/2 of these cardiac events are due to hypertrophic cardiomyopathy, and the others are arrhythmia, again, presumed arrhythmia. There's also tachycardia here. The blue ones are those that did not survive. Very interesting, all the resuscitations of the cardiomyopathy, the hypertrophic cardiomyopathies were not survived, and mainly the myocardial ischemic, the myocardial infarctions, they could be resuscitated and they survived the resuscitation. Where are the congenitals? No, not a single case of congenital heart disease. Let's look to a bigger database. This is, again, America, but overseeing 26 years now. All the subjects are below 40 years, so much less myocardial infarction there. And they investigated sudden death, not in a sport event, but also during training. These are athletes that train, have their competitions, and these are 1,866 deaths of those athletes. Where do they die from? Injury, suicide, pulmonary events, drugs, all these were excluded, and then you have 1,000 cardiovascular events, and even there 1/3 is only presumed cardiovascular events. Those are really, this 690 are confirmed cardiovascular events. And again in the statistics, the Hawkins with the 250 are the biggest group, and here are also the possible hypertrophic cardiomyopathies and coronary anomalies, those with the intramural wall, and here the coronary artery disease and the LID bridge have a big issue. But here also the Italian problem, the arrhythmogenic right ventricle, some myocarditis, ion channel defects, and then here aortic rupture, aortic stenosis, we are coming closer to the congenitals. But again, you won't find real congenitals, so we have to look what is these 36 others in detail. And now we find 8 subjects with congenital heart disease. Unfortunately, they did not split up which kind of congenital heart disease. So to summarize, sudden death because of congenital heart disease is no problem in athletes. That is a little bit different what we assumed to see, because we are looking at the patients and they even have sudden death. Are they not performing sport, or are they not athletes? So, make the studies otherwise round. I looked for studies from congenital cardiologists, how they describe their problem with TGA and sudden cardiac death, and there was only one single study that described the circumstances how the patient died with sudden death. That was a study from the Netherlands, about 4 or 5 centers in the Netherlands and 1 center in Portland, the Portland Center. They found 36 sudden death and 13 near-miss sudden death, and they investigated the circumstances. When did they die? And indeed, 80% died at exercise. So exercising for patients with atrial redirection, I'm talking about Senning mustard patients, have an increased risk to die, have at least a risk to die at exercise. The next step was that they try to extract risk factors, and they found that the symptoms the patients were reporting are the most significant risk factors. And interestingly, it's not only the arrhythmic symptoms, it's also heart failure symptoms that became significant in that analysis. Additionally, the history of arrhythmia in follow-up with documented arrhythmia were significant, and the documented atrial flutter, and atrial fibrillation. So it's not only the ventricular tachycardia that causes sudden death, there are also atrial problems that probably went into a ventricular fibrillation and caused this sudden death. And it was those patients that needed antiarrhythmic medication that was a large risk factor. Interestingly, in this study, not significant were all the variables from the resting ECG, from the Holter ECG, and X-ray. But there are different studies that did not investigate the circumstances, and they indeed also have other problems we heard about yesterday. For example, the QRS duration is a risk factor for sudden death in atrial redirection patient. So I end up with a sport recommendation for patients with atrial redirection. I could not, there are some of pediatrics, but for pediatrics, atrial redirection is no issue anymore. So I stick only to the adults. There are the Americans, there are the Europeans. The Europeans think very simple. They just say no competitive sports at all for patients after Senning operation. I'm not sure whether that is the right way, because why should not they be able to do golf competitions even at the Olympic level? And therefore the American, they are much more detailed. They say that selected patients can engage in low and moderate static and low dynamic competitive sports. That is billiard, that is golf. The moderate statics are even, for example, sailing is moderate static. But only those are allowed that have mild or no cardiac chamber enlargements in chest or echo or cardiac MR. They must have no history of atrial flutter, supraventricular tachycardia or ventricular tachyarrhythmias. They need no history of syncope or other cardiac symptoms. They need a normal exercise test defined as normal duration of exercise, normal workload, normal heart rate increase, a normal ECG, and a normal blood pressure response to age and gender. What are the recommendations for the new generation of patients after atrial switch operation? For this group, we did a very recent workup for recommendations together with the AEPC and a group of Europeans that are working in that field. It's online since August. And we, in accordance with the American recommendations, say that there are no limits for patients with after atrial switch operation if there is a normal ventricular function, no atrial fibrillation or flutter, no tachycardia, no aortic root dilatation, and a normal exercise test. So I'm coming back to our initial question. Exercise capacity, are Olympic Games realistic? Having in mind our patient I presented in the beginning, having in mind that most of the patients, all of the patients get now the better atrial switch operation, having in mind that there are no studies on risk after atrial switch operation and sudden death, I really have to conclude that Olympic Games are unrealistic, because for everybody of us, Olympic Games are rather unrealistic, but they are not impossible. Thank you.